I could also try this other laptop, but somehow this laptop needs a very strong network. So I might try to log in with another gadget. Let's see as it loads. Still loading.
All right. I think it's 7:05. We can start as the rest of the people join in. So right, Florence, as you're setting up, I can just do a few preliminaries. So good evening, everyone. Welcome to this KPA webinar for the month of May. Hey, we're in March. I don't know why I'm already in May in my head. Oh, I know why. But it's March, it's not May. My name is Dr. Wawa, and thank you for taking the time to join us. And today we are going to talk about play therapy as a treatment intervention in the medical setting. It's very interesting because I think I had Florence give a talk at KNH. It was like a month ago, and I was really excited about what she talked about, and I thought it's something that we should all hear about, and I hope we learn and we know what happens in children's therapy, play therapy, where to refer, and which children would benefit from this. So before we start, just a few reminders. 3 CPD points will be awarded for this webinar. Then we're also reminding members that it's a new year and we need to renew our membership. So just make arrangements to do the payment. And also in the next, this is why I was talking about May, because I'd been told to talk about this. So we are also preparing for May mental awareness month. And as usual, as you know, we just try and get a lot of visibility out there, KPA, to talk about mental health issues. And there's usually public webinars, street chats, a lot of engagement on social media. So we are asking for members to just come up and volunteer to do these different tasks that we will be putting up when we call for volunteers. So I think I can now introduce our speaker for the day. We're going to have Florence. I know Florence personally, and I have to say she's the bubbliest person I've ever met. Like you can't sit in a room with her and not be happy because of just how she talks and her demeanor and all that. So she's a very exciting person to listen to and be around. So Florence is the chairperson of the Association of Play Therapy Kenya. She's also the Assistant Director for Probation and Aftercare Service, responsible for rehabilitation and supervision programs for special needs offenders, including those with mental disorders and children in the remand system. So Florence is joined today with two of her colleagues who she'll introduce. They work together at the Play Association of Play Therapy. So she's going to just introduce them, and then she'll start giving us her talk. Any questions that you have, kindly key them in the Q&A section. Okay, karibu, Florence.
Thank you so much. Let me put on my camera so that people can know me. So thank you, Sarah. My name is Florence Mueni, like she has said, and I am here with the two members of APTK. APTK is an association that was started in 2020, but even before the official registration of the association, there had been a lot of discussions and conversations and meetings about the need for people working with children, psychologists and counselors that are providing mental health services to children to just create a community, come together and create a community to advance the cause of play therapy, and of course to do other things that professional associations are registered to do. So I have with me Olpa Apola. She is the vice treasurer of the association, and I have the vice secretary, sorry. Olpa Apola is the vice secretary of the association. And then I have Maureen Jenga. She is the treasurer of the association. So there is Maureen. So we are so glad as APTK to have this opportunity to speak to fellow colleagues in the mental health profession about this treatment modality for working with children, because that is primarily what APTK is for. So I am looking forward to sharing experiences and also my experiences in working with children. And I've emailed you the presentation so you can share it. And I'm also looking forward to hearing from you in terms of how we can integrate play therapy in the medical setting. So Dr. Wawa, have you received the presentation?
I have received it. It's downloading. As you had said, it's a big document, so you can start talking as I finish the downloading.
Okay. You tell me when you're finished, because I'll just be starting with mine. I don't know, for some reason, I'm not able to share from my end, but that's fine. Okay. So children, we have come from very far as a society in terms of the way that we view children. And I think in my history, you know, in my psychology classes, as I learned about children, there is a time that we used to look at children as miniature adults. Those are, you know, that was a long time ago, when children would even be working in factories and be employed, and they'll be wearing these long dresses, you know, and, you know, they just look like old women and old women. They will be subjected to severe punishment. And, you know, maybe even cruel medical procedures because nobody understood. I think that was the period of before the philosophers or something like that. But then we have changed a lot. Science has informed us about childhood as a special stage in development with a lot of dynamics. And, you know, I work in the justice system, and if you have been interacting with the justice sector, it is just last year when we even upgraded the age of criminal responsibility from 8 years to 12 years. That's progress. You know, we have a long way to go, but that's progress. It shows that we are beginning to recognize that moral development isn't really complete you know, if you as psychiatrists could help in informing people about even the brain and executive functioning and, you know, decision making, and a child being able to know right and wrong. But then, even though there has been so much progress in this area, there is still the notion that, you know, when we are seated with a child before us, it has to be very intentional. And, you know, the person, you know, like ourselves, mental health professionals, being able to really be aware that what is going on in my mind and the way I'm looking at things isn't the same way that this person before me, they're 13 years, they could be a teenager of 16 years, but with a really big body, so they look like they're 21. But really, what the way that they perceive things, the way that, you know, they make sense of things isn't the same. So we have come from far. So in terms of providing therapy to children, one of the things that distinguishes them, and maybe you know this, is that children come from larger systems: the family system, the school system, the peer group system. I think the DSM also, you know, talks about, you know, if a problem is manifesting itself in more than 2 settings, you know, in the peer setting, in the school setting, in the home setting, then we know that is really a problem that is affecting the child's functioning. So these systems can potentially cause, and they can even perpetuate, psychological disturbance in a child. And that is one of the things that distinguishes a child from an adult as a client, because an adult can make a decision that I need to take care of my mental health, I need to go and see a psychiatrist. You know, I feel like, you know, things are really getting out of hand. A child will not. It is the parent, or maybe it's the teacher who writes in the report card and calls the parent to school. And that parent can decide, we are going for prayers. Oh, I will observe. They're still playing around and they're still performing, you know, they're getting good marks. So why are we worried? Or sometimes parents say all the time to us as clinical psychologists that I am afraid of taking this child to a psychiatrist because the psychiatrist is going to give this child medicine and this child will become so dependent, or they will not be able to function in class, they will be sleeping in class, you know, those kinds of misconceptions. So we know that in order to help a child, we have to work very closely with those systems. Children have limited verbal capacities to self-report their symptoms. So because of the limited verbal capacity and of course their developing brain, they might not come out very clearly. They say bad, they say good, or I feel like my head is heavy, I feel a lot of things in my chest, you know. So that means then, so maybe you can go to that slide, thank you. That means then the techniques that we use with children are not like, you know, verbal. So of course we help them. We use play therapy as a way of helping them to really articulate their needs. Then of course, treatment decisions, like I have said, are made by caregivers. So the caregiver might decide to get help for the child or not. A lot of psychoeducation is needed. As play therapists, what we do is to explain even that play therapy, because some parents say, I'm paying you to just play with my child. So, and you can see where the parent is coming from, because play is something that we see every day. We see our children play, but then we do not derive from that observation the biological values of what that child is engaged in. So we break it down in a language that a caregiver can be able to understand, that, you know, when you bring your child to a play therapist, this is what is going to happen, and this is how it will help the child. Sometimes we have even to show them, you know, videos that have been made by play therapists just talking about the value of play therapy. Then of course, the other thing about children being different is the issue of confidentiality, that while an adult's treatment might be 100% confidential, parents have a right to know about what is happening in therapy with their child. But then because they'll be given that by the law, the Children's Act 2022. But then the child also is entitled to their own privacy. Actually, this same law says the child is entitled to privacy, and then it also says that the parent has parental rights, and so they need to know. And sometimes even us as psychologists, I don't know about you guys, we have sometimes a dilemma, like when a 15-year-old walks into a counseling room and says, I need therapy, but my parents do not know. So can the parents go and sue in court and say who provided this treatment without, me giving the permission? So, but anyway, there is a time for feedback with parents. But that feedback is given, we give it, as some kind of just the overall the themes of the child's issues, and then narrowing down to emphasize what the parent can do, because remember, they are part of the child system. So what can you do in order to help in the treatment of this child? There are specific treatment modalities for children, or theories on approaches and models of working with children, especially those up to around 11 years. There are even modalities for working with infants, yeah, infant mental health, and we have those. So taking on a modality that has been designed for an adult clients, and then using it on a child is like, of course, cannot work. I wanted to say it's like putting new wine into old wineskins, but then I'm thinking, okay, so am I saying that the adults are the old wine and the children are the new one? Probably, yeah. So it cannot work, and so we use modalities that were normed on children, and there have been specifically the research shows that it works better with children than with adults. And then, of course, with children, we take therapy to the child, even as the child comes to us. So there can be the professional setting where the child comes to see the play therapist. They will come in my practice and I will see them. But then suppose I am called by a parent and they say the child is so traumatized, something happened, and they do not want to get out of the door. Their neuroperception of safety is such that everything is not safe. So I can do portable play therapy by just packing a few things in my play therapy bag and just going to that home, in a children's institution, in a children's home, in a school setting, in the community somewhere. So unlike adults, it's possible to go and see even groups of children, in a school. And I have been able, like, for example, to respond to a bit of the emergencies that we have in the country, school burning, school accidents, child dying in school, things like that. And the whole class is affected. So those are some of the places that we respond. Next slide. So this is a small reflection, and I don't know whether the chat is enabled. Is it enabled?
Yes, the chat is on.
Yes, it is
Okay.
on.
So
Yeah.
here's a small assignment, a reflection. Imagine that you are a child aged 2 to 11 years. You have been admitted in a hospital. What kind of thoughts would be going on in your mind? Or what kind of feelings would you experience? So maybe you can type in the chat, what kind of thoughts, or questions would you be asking yourself? What kind of feelings would you be experiencing? And maybe you can read to me some of those, because I can't see. Now I can see. Okay. Oh, only one person.
The chat is enabled. Anybody else can write.
Yeah,
Like
it
if
seems like you're
yeah.
the only one who has put in anxiety. So I can see there are about 36 people present. I hope that they can hear me, or maybe they can't see the presentation. They can't hear. I'm not sure. Okay, so please keep doing that. Next slide. Okay, so child clients in medical settings, of course, the medical
sorry,
setting.
the chat is disabled. That's why they were unable to see. But I think
Oh,
you can
okay.
you can
Okay,
still put it in
let
the
them just,
Q&A.
huh? Or
Because
we
I
can
see you
use
can
the
the
Q&A.
Q&A, you can write in the Q&A then.
Okay.
Mm.
Let them use the Q&A. Fine, let them keep coming. We'll look at them. But this slide is talking about, children in medical settings. That medical setting is not a child world like the school. It's an adult where children are expected to navigate it, even though they have those limited coping skills that we just talked about. So the child comes into the medical setting, not only with an illness, but a sense of lack of control, a lack of control of what is happening in the environment. And of course, frozen development, so that a lot of is being done for them because maybe of the illness. Maybe they had already been toilet trained and now they have to use diapers, things like that. And of course, milestone achievement is a very important thing. So the child, of course, delays in terms of achieving that sense of milestone. And of course, children make their own versions of illness, whether it's a physical illness or it's a mental illness. They have what the adults tell them that they are suffering from, but then there is what they tell themselves, like that is what they hear. And sometimes, a child might have a conduct disorder, for example, or ADHD, and when you ask them, they say, I am a bad person, or I can't concentrate in class. I don't finish my homework. I'm always getting into trouble. So can you imagine, we the adults know the child has that, and the child is interpreting it to mean, they are not good enough, or they're not, they're not like other children. So a good place to start would be to understand that child's phenomenological view of their own disorder or their own medical illness. And of course, if they get admitted into the hospital, for example, we know separation anxiety is a big thing because, the people that they know are not there. Even when the babies are admitted with their mothers, it's not the same environment. And that adult is also distressed by being in that environment. And we know a dysregulated caregiver is equals to a dysregulated child. Yeah, next slide. There is, of course, a bit of guilt and loss of sense of mastery of developmental milestones. And of course, if they have a physical disease, of course, we know, like our DSM tells us that, physical illness can lead to psychological disorders and vice versa. And so when we are using play therapy, we want to look at those two things. And, the stage of the disease and, how the child is coping psychologically with what is happening to them. They get worried and anxious. Of course, when professionals withdraw support and become unavailable to the child because maybe they have to attend to other children, children become anxious when they are not informed about their diagnosis. So anxiety is one of the things, common disorders with children in medical settings. Next slide. You can discover more about a person in an hour of play than in a year of conversation. And this is Plato. I don't know the context in which he said this, but looking at this, for us as play therapists, we know that play isn't just something that can be used for people under the age of 18. Play is something that also can be used with adults. And in fact, the research is now showing elderly people are responding well to play therapy. Of course, the research is still to, to be conducted with many populations, but that's one of the things. So yeah, you can discover more about a person in an hour of play than in a year of conversation. If this was a physical meeting, we will do a lot of activities, but that's all I have to tell you for now. Next slide. So what is play therapy? So play therapy, as you can see, this definition by the Association of Play Therapy, USA, is the application of very well documented and researched theoretical models. And we use those in order to establish that relationship between the child and the play therapy. So there is an interpersonal process, knowing that naturally in a relationship between an adult and a child, the child is lowly placed. But in play therapy, we look at it as the I-thou relationship, meaning that even though I am an adult, and for you doctors, so I am a doctor, and doctors are revered people. You have a special place in society. People look at you as people who have all the answers to their illness, and you can fix this, which can be stressful, I think. And you have a white coat. So the interpersonal process means that breaking down some of these, we as adults, them as children, barriers, for the child to be able to look at you as this person who understands my feelings. So training is very important. And then we use that play, which is the natural medium of communication for children, the therapeutic aspects of children's play, in order to help them to deal with the issues or the psychosocial difficulties, of course, for long-term optimal growth and development. So that's the definition of play therapy. Next slide. There's a lot of research around play therapy. Schleifer and Drews interviewed many psychologists and therapists and asked them, what is it about using play therapy that brings change? So they wrote this book, compiled the data, and it was translated into this book called The Therapeutic Powers of Play. So in summary, play develops fine-tuned social brains that can correspond optimally to developmental demands, just the play of children. And it seems to be, for them, they found that play seems to be one of the most advanced methods nature has invented for the complex brain to create itself, for those neurotransmitters, for the brainstem, for the limbic system, for the perception of I am safe, for access to different aspects of brain. Play for children is something actually very advanced and complicated. I hope that after this session, if you have children or you have children around you, you will take a moment and just observe the way they navigate through difficult things, making them look so simple. And of course, we know at that time, when a child is moving a vehicle from one corner to another, a car, they are saying things. They're engaging in fine motor skills or even gross motor skills. Their brain is engaged. They are regulating it so that it does not fall and it goes in the right direction. And, their whole brain and body is engaged. So that's why I think, Brown here says it's one of the most advanced methods. Next slide. So what they found is that the mechanisms in play, it is the mechanisms in play that actually produce the desired change. I'm just laying the foundation for you to be able to understand how play inside the playroom is therapeutic. So it is the mechanism of the child's play in the playroom that actually produce the desired change in their dysfunctional thoughts and feelings. So the specific change agents that play initiates, of course, does facilitate and strengthens that therapeutic effects. So it is the play itself that produces the change. It is not that the play is a medium. What do I mean? So you have a child in your office and you keep some toys at the corner of your office. And so you want to talk to the child. So you give the child the materials and you tell them to hold one or be playing with one. And then you start having a different conversation, not focusing on what the child is doing. But what play therapy is focusing on what the child is doing. So it is the play that actually produces the change and is not the medium for change. So, like for example, so you might have maybe some family dolls, somebody that looks like a man and a woman and some children and maybe some animals there, and the child takes a child, and they take, a mom, and the mom starts holding the child. So as a therapist, your job is to respond and to reflect on what the child is doing with those two toys. And we'll see later, maybe, as we talk about the techniques. So the empirical, go to the next slide. So there's empirical evidence about play therapy. There is a lot of meta-analytic studies that have been combined and, to show the effect of play therapy. There are RCTs, that is randomized controlled trials, and quasi-experimental studies that have proven that play therapy is effective in treating a variety of children's disorders. And like I said, some of these models of treating these disorders or these problems have been certified as evidence-based and licensed. And, for us as play therapists, especially in APTK Kenya, since we started our association, what we've been trying to do is to make some of this treatment accessible to mental health professionals in this country, so that they are not just using generic skills, asking the child questions. So what do you like? Tell me what happened. What is the basis of that? So child-centered play therapy, for example, we have even done our webinar and training of our play therapists on this. There is an approach called TheraPlay, which is very good for children who are reconnecting with their parents and, attachment bonds and all those kinds of things. So there are many others. You can see there is a children's version of Gestalt therapy. I'm assuming that maybe in your class you may have read about some of this. If not, maybe we can talk about them later, or you can ask questions. There's EMDR, there is a playful version of it, which treats trauma, complicated trauma, cognitive behavioral therapy, which is a bit advanced, probably for children, but there is a cognitive behavioral play therapy, which breaks down those complicated, thoughts, feelings, behavior, things, the way we talk with adults. For children, we do different things, but we are using CBT. Next slide. Okay, so what are the goals of play therapy? Of course, we are clinicians as well, especially those who have done clinical psychology. Our counseling profession is really broad, but even us as counselors, we have goals. When the client comes, we do assessment. We do get a diagnosis. Then formulate treatment goals. These are just general goals to bring about some relief for the emotional distress of children, get that diagnosis. And of course, for the diagnosis, there are assessments. There are assessment tools that are specific for children. So many. There are so many. If you go to the website of National Child Traumatic Stress Network, for example, that's a place, National Child Traumatic Stress Network. That is a government website, not our government, of course, we will get there, that lists some of the tools that have high reliability and validity values that can be used to diagnose different issues in children. So the thing with some of these children assessment standardized tools is that they have the child's version and they have the parents' version. So it's good to administer both of them. And, the ones for children, depending on, the targets, if they are for like 10-year-olds, they are really brief and they ask grade 3 questions that the child can be able to answer. So assessment is so important. If so of course, we all know that some of these tools are very expensive to buy, but then there are also those that the developers have made them available. It's really important. And I think there are tools for everything. There are behavior tools, there are for anxiety, there are for depression, there are tools for other mood disorders. There are just so many tools. Personally, what I've been doing as a clinical psychologist is I have this folder where when I come across a tool, I just put it there and then I will read about it, look at the way it is scored and interpreted and all that. And so that in case I get a child, because you don't know what's going to come to your office, in case I get a child, I have a tool that I can be able to use. So there are so many out there. Very important. But then again, beyond the, I think there's even a child state version of the MSc, mental health state, what is it called? Mental status exam, mental status exam. Yeah, so there's a child's version of that. And it's so interesting, the way the MSc for children is, sometimes I use it and I'm looking at, is the child looking at me when we are talking? Now, that can be so faulty sometimes, because when the child comes into my play therapy room, they are so interested in the toys that eye contact with me is not, they are not interested so much in that unless they're directly talking to me. So I might say, child, that not keep eye contact, but that could be so wrong. So beyond that, there are so many, the clinical interviewing even of the parent is so important, because as you speak to the parent, you can even be able to see this prognosis is not going to be good, because this parent, the marital dyad, for example, is so dysfunctional. They are not together with the father in terms of, just being in tune with about the child's treatment. So they bring the child the first time and they don't bring again. Yeah. So there are so many dynamics in terms of assessment. Next slide. I think you've been able to read that, and I'll leave this presentation. So the benefits of integrating play therapy in medical settings are many. But then, of course, for holistic treatment of the child, body-mind connection, so play therapy will bring that, mind, the social, psychological aspects of treatment, so that there are positive outcomes for the child's treatment. And then, of course, it helps the child to be able to process that anxiety of being sick and maybe being in an hospital, dealing with the separation anxiety. And there are many tools for helping a child deal with separation anxiety, including bibliotherapy storybooks. I'll show you some of those. And then, of course, the decrease in physical symptoms. When we do mindfulness, when we teach the child breathing, when we teach child thinks that they can use themselves, they can do with their own bodies when they feel a bit of anxious. So there are those things. So the benefits of play. Next slide. Of course, hospitalization is not a positive experience for anybody. And if we adults with our coping abilities find it not a good experience, can you imagine for a child? So it helps to make that experience tolerable. And of course, multidisciplinary work, helps to increase that accuracy of diagnosis and providing the child with a familiar experience in this environment. Next slide. So the application of play therapy in a medical setting, or the play therapist in a medical setting, is it helps the play therapist acts as a co-regulator. So as a doctor, you can actually act as a co-regulator of the child. In my very lay person's language, I'm imagining, like that thing you used to take the fever or the temperature. So the fever is high, so you give some medication to make it go down. So the anxiety of being in a hospital is high. So you're making it go down. But this time you're using play therapy. I know it's difficult for you, miss your family, stuff like that. What would help you right now? So presence of a play therapist helps the child experience a sense of safety. So, we know the role of the parasympathetic system. You can rest. There is no danger. you can relax. So when the child has that, and it's not just, I know, like in some hospitals, you go to the children's ward and you find there's a teddy bear on every bed. Okay, I can hold the teddy bear. That's good. Maybe it's a transition object and provides me with some sense of comfort. But if there is a person, coming and we are having a session together, maybe this teddy bear, we can have a role play, and this teddy bear, which can be used as a puppet, actually, I can have a conversation with it. And, what would the teddy bear say back to you? Say, I'm here to keep you company. I know you can be scared sometimes, but you can call me anytime that you want. So we are making that teddy bear become a protective factor, helping the child. So of course the play therapist safeguards the child's mental well-being and provides that child with medium of emotional release through a variety of materials. Next slide. So when is it appropriate to use play therapy in a medical setting? When do you think it's appropriate to use play therapy in a medical setting? Now you can still put in the Q&A.
I think the chat was enabled, so they can put it in the chat.
Okay.
I'm not sure.
Okay, let's try it and see if it's going to work. When do you think is appropriate in that to use, or what stage, where does it fit? Seems like, okay, they can still come. Although, okay, so as they come, I'm looking at what you had put about what you would feel, fear, worry. Yeah, I'm going to die. Where is mom and dad? Oh, yeah. Fear and anxiety, then abandonment in the hospital. Yeah, all those things is what the child would be feeling. So next slide. So somebody is saying all the stages. That's yeah, that's true. All the stages. So let's have the next slide. Okay, so this is just some of the areas that I thought would be very appropriate when communicating a diagnosis of the child or a diagnosis of a family member. And I was wondering, you know, I have had family members go to the hospital, and we have had, you know, the children are affected when their mom or their sister or their auntie. I don't know. Do you guys, you know, call the children on the side and break it down, even as you talk to the adults? You know, if there are children there, or do we assume that okay, so I've spoken to the adult family members, so that let them go and speak to the children? Or do we ask, are there children that might be affected by this person's illness? If it's a dad, you know, are there children, and how can we help the children? That's very important to think about when we are explaining the role of different actors. You know, in the hospital, children see so many people, and so everybody's a doctor. It's like where I work in the justice system, everybody is a judge. So they'll say the big judge, the small judge, the judge that writes many things, the judge that carries many keys. The only person they can distinctly identify is a police officer because of the uniform. But even that police officer, if they don't wear that uniform, from that day, they'll be given, you know, the same name. So, you know, it's a complicated system, like I said, for adults. And we can explain the role of the nurse, the role of the person who is coming to withdraw some sample from the child. You know, even the one who comes to sweep is also called a doctor. You know, so the children don't know who are these people. They're coming and say, hey, how did you wake up? Okay, so now this is what we are going to do. So we explain what is going to happen next, but they don't know who's doing what. Teaching the child pain management techniques can be a good place also to use that. Admission into hospital when they are coming in, and we can when they are coming, and it's always good that parents and families are taught to prepare the child and address the anxieties, medication. You know, I have a play kit in my play therapy room, and when children are playing doctor, it's like I get to see their perception of doctors. You know, so they'll take they line up dolls or people there, and then they start treating them, and they will just take an injection and drive it through an object's hand, or sometimes I become the patient. And I can see by the way this child is treating me, I can be able to tell many things. So some are tender and soft, and they try to encourage me, and they tell me, oh, it won't hurt. I'll just, don't be scared. Then others, they just take those things, and they'll take the one for removing teeth and tell me, open your mouth, and off they want to take off my teeth. So for things like that, for medication, we can explain injections before conducting procedures, post procedures. Maybe a child has lost a body part. That's for me. I have seen children who have been involved in accidents and lost body parts, and that is such a big loss to them, that sometimes I even ask them to write a letter to that part that they have lost, and tell them how they feel that now that they don't have that part with them anymore. And then it's not just about writing that letter. Maybe they've lost, a finger, or they've lost a hand. Then we'll ask if it's one hand that has been lost, let's have the other hand reply and say how they will help, they will work, or how they will, help the body. So when you have this positive negative experience, then you bring it another positive experience, or something that is like a resource, so that even as we experience the loss of the hand that has gone, or the hair, maybe the child has cancer, and so the hair is gone. So, we can write a letter to the hair that has gone. But then how about the hands say something that we will be washing your head, depending on the age of the child, of course. So things like that. Communicating about death of a relative, our fellow patients. Loss is a complicated thing for children, and as a society, sometimes we struggle on how to do that. Children want to come to the hospital and see the dead person and say goodbye, but sometimes we think they will be traumatized by that. I have seen children being stronger than adults gave them credit for, and they see as long as they are told what to expect, and then immediately after whatever they see, maybe somebody is there to support them through the process. Next slide. So those are considerations of play therapy, of using play therapy. What should be considered if play therapy is indicated. So of course, what is the diagnosis? Is it something that can be engaged in, or not? So diagnosis determines also, because maybe it's not the right treatment, but assuming that it is, what are the physical limitations? Is a child in a wheelchair? Is a child supposed to move? Play, the child does not even have to move. The child has so many senses. They have the sense of seeing. They can see things. We can show them things. We can read to them a book. They can touch. They can touch clay when they are on the bed. But of course, what they are limited, we look at what they are not limited in. So then, of course, we are looking at infection control. So like maybe the child is in a ward. Are we taking clay there? Probably not, because clay carries bacteria. Are we taking sand there? No, we are not taking sand there. So what things can we take that do not spread diseases? Then effects of medication on client attunement. So is the child able to engage in therapy at certain signs, or it's other times, when the medication has worn off? The support systems available to the child, the family, and all that, because they can be able to help us. We do our part, the family does their part. The child's views and assent is so important. In my work with children, I've come to realize that sometimes we assume that children do not have a view of their own. And so we can be seated there beside the bed or in our office, explaining a diagnosis and treatment to the parent. And that 6-year-old child is there just fidgeting, and they are listening. They are listening. And, it's very important to unpackage that and ask if they have any questions, and ask what mom can do, or what dad or what auntie, whoever can do in order to help them. So their views is very important, and just listening to them, and also their permission, their assent to do some of the things that we do. It makes them feel heard, and it is very important also for their treatment. The dignity of the person, of the child, in terms of that confidentiality also is very important, because therapy in our office is, of course, is not the place to like reprimand a child or to like threaten a child. I once, worked in a place where, children would come with self-injury, so they are cutting and they have suicidal thoughts, and the parent comes and the parent is worried, and the child is told things like, you want to die so that you can leave your mother suffering. So probably that is not therapy, that is something else. that can happen in another setting, like where I work in the justice system, we threaten people there, but then again, it doesn't help a lot. So the dignity and using child-friendly techniques throughout the phase of treatment is very important. Okay, so next slide. So what techniques then are these that we are talking about? If we are going to see a child in a hospital setting, we should not carry things that are too complicated, like you're carrying blocks, that the child is supposed to spend like 10 hours constructing something. I think this is a season for construction blocks. They do make children pay attention and not bother us a lot, but they're only engaging, the brain only, there's no movement. Yeah, but we don't carry things that are too complicated, not too heavy, things that would cause children allergic reactions. They should be variety, sensory, thinking about the senses, not the child. Knowing the child is important so that the child is not forced to engage in an activity that they are not comfortable in. Yeah, then a mix of course, medical related materials, but then not too much, so that the child is not overwhelmed. I'm already in a hospital, so every time the therapists come, they are just bringing me, stethoscope or, a doctor's kit. Like I have too much of this, so just a variety. Next slide. So of course, intake with the child, I know that we have been trained in how to do intake with the parents. So I didn't focus on that. In fact, for us as clinical psychologists, we actually use the medical model. So, but for me, I vary mine a lot where I feel it's not appropriate. But I'm talking about after talking to the parent, need to talk to the child so that we can get their self-report. So those are some of the things that we can be able to ask children. And of course, using these techniques that I'll be talking about. Next slide. Okay, so we are going to look at a few samples of techniques that are used with children. But remember that some of these things are anchored on theoretical models, like I said. And I imagine that doctors do a lot of check-ins. We also do a lot of check-ins. When a child comes into my session, before we start, maybe I saw them a week ago. So many things have happened. I want to start by a check-in. And there are so many ways of checking in. So I have a chart that I can display. And, like this one you're seeing, it's a feelings check-in. And I ask the child, to show me the emoji that looks like how they are feeling. So maybe they're feeling disappointed, that girl there, So we talk about that feeling of disappointed. What's bringing that feeling? Next slide. These are just different ways, Okay, how do you feel right now? Pick one positive feeling you had. Yeah, so this is like a thermometer check-in. We can do a weather check-in, and this is, I'm just asking them to either draw, or I show them a chart that has already been drawn, like this one. So, if you are a weather, what weather would you be? I have pictures of cats in different, positions with different faces. So, which cat are you today? Oh, I have pictures of the cartoons that they watch. So, which SpongeBob are you today? So, next. Yeah, that's the same, If they say sunny, tell me what's sunny. Tell me about yourself as being sunny. They say, I'm happy because I did not feel any pain, and that's good. Next slide. Mindfulness techniques are very important because these are things that we teach the child to use in the session and then to transfer that into the other settings where distress might happen. So practice makes perfect. And I have seen children, sometimes, we do some of these breathing techniques in the sessions, and then they come and say, you remember what we were doing last session? I did it. There was an exam, and, I tried breathing like that before I started the paper. Or, I met this bully, and then, I was scared, and then I did that. Or mom and dad were fighting, and I was scared, and this is what I was doing when that was happening, stuff like that. So there are creative ways of teaching children how to breathe. And of course, as doctors, I think the value, the neurobiological value of deep breathing, a deep, intentional, focused breathing. So with simple things like, bubbles, those bubbles that children blow, and I'll tell them they might not have a bubble in that situation. So imagine you have the bubble. So in the session, we have the bubbles and we blow the bubbles. And I tell them, you take in one deep breath and then you hold it for a minute and then you blow the bubble. But then you don't have the bubble in the class, maybe. You will not have the actual bubble in a certain situation. Imagine it. Imagine you have this big thing. So you're feeling angry. Imagine you're going to blow a big, fat bubble. So that's one. Pinwheel, using shapes. So square breathing, for example, is having the child draw, or you can draw a square. And then through, you're like, through the lines of the square. So you breathe in, you hold it. You breathe out, you hold it. You breathe in, you hold it. And the chest here, our chest is like in a square form. So I tell them, imagine when you've drawn that square, you can even, okay, so you guys can't see me. I don't know whether you can see me, but I was gonna show you. Can you stop the slide for a minute? Oh, it's not possible to like stop sharing. So anyway, so they can even use their hands. And they can trust their hands as they breathe. Guided imagery is about taking them through some imagination. So first you have the child relax, and depending on the child, you don't make it long, because if it's a young child, they will be bored. If it's an adolescent, can go all the phases. If it's a preteen, a bit medium there. But this imagery is probably targeted at something. Maybe it's anxiety and the child gets panic attacks or something. Or maybe they feel bad when the teacher calls them in front of the class, or I don't know, whatever. So so close your eyes. Just do a scan of your body. Like imagine you're holding a magnifier and you're taking it through your eyes and all that down. And then imagine that you are in this place and there's no fear. Like it's your safe place. You are so calm and you're so relaxed. Tell me what you see. Tell me what you hear. Is there something you can touch there? And you can even take it further by having the child draw the safe place. And you do that. And then, when they're in that other situation out there in the environments, they can use that. So mindfulness techniques are very important. Next slide. Oh, is it over? There were more slides. Are you there, Dr. Wawa?
Yes, I am. Just give me a few minutes. I think I had resumed. I had paused, so I have to figure out where we were.
Okay, go up.
Therapist, returning. Figures.
Mindfulness.
Sorry about that.
Okay, we can stay with the art. Yeah, I think that was the next one. Let's see.
Yes.
The next one is the art. Okay, so art in forms of drawing. If it's in a setting that you can use painting, that's okay. Art is really broad. Clay is also a form of art. But art is so important because it gives the child the permission to determine what they want to reveal about themselves. It helps identify personal strengths. And, it's just about what the child has drawn and having the child explain to us what they have drawn. It's not about projective testing and looking at which line is fatter than the other and how much space has been used. I think the research is showing that there are so many errors when we try to interpret drawings without the benefit of having the drawer explain to us. And for children, really, of course, we use the drawing together with the information that we have about the child. So drawing is very important because it's a useful medium, because it helps, it's a window through which we can be able to see. So the child makes a drawing, and then we ask the child to tell us what they have drawn. And then, we process that by just listening and asking them open-ended questions. But sometimes we can even have ask the child to talk about the different parts of that drawing, and have those parts of the drawing maybe have a conversation with each other. So so art is a very important medium for working with children. Let me see, next slide. Okay, yeah, so just an example of some art. And when you look at this, you might wonder what this is. And like I was saying, I find mental health professionals focusing so much on interpretation and losing the therapeutic aspects of it. But when a child does a drawing, the first one, actually, the red one is I hope I can be heard. Can I be heard?
Yes, I can hear you.
Okay. So like the first drawing is actually an anger. That's a child who is angry. The other one, the one with the beads, which is written orange heart, is about my inner resources, what I can use when I feel distressed, when I feel anxious. So drawings is a very important technique. And I think in the medical setting, since, they're just a matter of paper and pen, is something that can be easily used. Next slide. Music. Okay. So, of course, music is a good distraction to pain, especially music that has been chosen by the child in terms of their preference, something that they like. And even, just playing that music to them, we know that music is really relaxing. So use of music is very important. Sometimes you can ask a child even to write a song or some lyrics about a situation that they are going through, or about their disorder, so to speak. And they do. They just create something. It does not matter. It doesn't have to be like a properly done thing. What matters is their expression of it. Yeah. With traumatized children, when I work with traumatized children, I find that when we start the session by playing some movement song in my laptop, so I set it up, and then we start with some music that has some dance and movement. So it's requiring us to engage in some action, maybe a freeze and stop kind of song, not these other pop songs, but carefully selected to maximize on movement and feelings and all that. Then we sit down and we do something else. And I see some children always reminding me, can we start with music? Yeah, I've seen some children in the middle of the session. I remember one time I was working with a child who had been sexually abused, and I was we had worked, and then I was using a model called trauma-focused cognitive behavioral therapy, which is recommended for children who have gone through trauma, especially sexual abuse. So she had just, we had reached the stage where we were talking about the trauma narrative, and the child drew the trauma narrative, and we talked about it. Then she said, "Can you play me a song?" And I said, "Yeah, of course. Which song would you like?" Then she said the song, and I played the song, and the child just started making some movements, and and after that she said, "I feel good." I had another child, baby, like I think 6 years, severely traumatized by physical abuse. And when they came to the session, she is actually the one that asked for a specific song. So I play that song for her, and then she tells me, "Can you hold me?" And I in that moment, I just knew that I needed to do that. Like there was no way I could say no. I said, "Of course, I'm going to hold you." And the child just calmed down and listened to that song. So music is so important as a therapeutic tool for children. Next slide. Yeah. So the world of children is very influenced by the media and what they watch. And, superheroes and villains are things that we talk about in the playroom a lot. And, like we said, we are using the language of the child. So in a play therapy session, sometimes I would ask the child, think about your situation or your sickness or whatever as a villain. And look through the shelf and see a villain that best represents the challenge that you have, and then pick about 4 or 5 superheroes who have qualities that you think can help take care of this problem, help you cope. So it could be a superhero that is brave. It could be a superhero that is calm. It can be a superhero that is confident. It could be an angel like this one that, that I believe that I'm safe because God is watching over me. So this is a sand tree session, where we help use that way in so many other ways. Of course, the sand tree is used in so many ways. But, this is a language that the child, even a teenager, can be able to understand. And then we process that session by just looking at the resources that the child has. Next slide. Okay, puppets, they provide that safe distance because when the child is wearing the puppet, they can be able to project their feelings and thoughts and behaviors onto the puppet. So it can be a courageous, aggressive puppet that is, facing a situation. Or it can be puppets about feelings. Sometimes I ask the child from the puppet tree to pick, a puppet from your present situation and a puppet from your future situation when this problem is not there. So the child picks a puppet from the present situation and a puppet from the future situation when the problem is not there, and they put them on each hand, and I say, how about the 2 puppets speak to each other? So they speak to each other. Or a puppet can be just for creating rapport the first time you come. "Oh, welcome. We live here in this playroom. And we are your helpers. We help children." So they pick puppet and, we get to know each other. I can put on a puppet in my hand and the child puts on one. And I ask for details about the child. And they give me the details because it's the puppet that's giving the details, not them. So that's safe distance. Next slide. So miniature figures, family figures representing different people in society: parents, children, teachers, pregnant women, doctors, teachers, policemen, whatever. Those are so important because when a child can be able to use that to show us the relationships that they have with people, including perpetrators, maybe. Maybe you're writing a report for the police. You have looked at a child, or maybe you're writing a report for court, like we do. And you want to talk to this child. So this can be used on the sand tray. Make for me your family. Put this in the sand tray. Think of your family members. Or sometimes it's the children who just take them and they manipulate them in different ways. So there are so many things that happen inside families. And of course, by having family figures and these things in the playroom, it helps us to be able to work with the child to handle those things. Next slide. Then we have bibliotherapy or books that have different themes for different issues, like divorce, peer pressure, sickness. You know, there are books for so many children issues. So they facilitate the child's understanding. So the books are important when we are teaching a child coping skills, when we are helping the child to understand a certain situation. The distance between the child and their problem created by the story helps the child process that issue. Next slide. So, so there are specific, of course, these books are specific with the therapy in mind. Next slide. I think that's where I have. So this is my play therapy space, and these are the samples of some of the books I have. So you can see there are books on, you know, when we are talking about divorce, sexual abuse, trauma, esteem, anxiety, medical issues. There are books that teach mindfulness, family relationships. You know, there are all books for all different types of themes. So of course, you read the book with the child, or read the book to the child who is not able to read, pausing to just talk about what's happening with that book. Sometimes I'll have the parent come in and read the book to the child, especially the ones about family relationships. You know, maybe the parent needs to attune to the child and be able to listen and identify the child's feelings. So I'll pull out something. And of course, we can talk with the parent about that. Next slide. As we come to the end, then there's clay, which is very good for any age and of course any academic capacity. Drawing needs a bit of knowledge here and there, but clay, the child does not feel limited because they're using their hands. It's good with anger. It's good with the senses, for fine motor development also. So children can create, they can even mold their bodies and their sickness, and maybe they can even mold a superhero that helps them deal with that. Yeah. Next slide. Yeah, then of course medical supplies include, you know, things like this kit, but then it can have all the other things like band-aids. Sometimes I actually, even when the child is not sick, I use a lot of these medical supplies, especially the band-aids and the cotton wool. When I'm doing parent-child sessions and you want the parent to learn how to take care of their child. So I'm giving you this cotton ball and check your child for hurts. And you see the child very ready to say, oh, there's a scar here. You know, I fell when I was riding my bike. Oh, there's this one. What happened here? Oh, there I was. I fell on the stairs. Oh, here somebody beat me and all that, you know. And it's a good way of parent-child connection. But then, of course, the child who is sick may use this tool to gain mastery, to be able to feel in control of over their illness. Next slide. Story cards. Of course, there are different cards that you can play with a child. Actually, this is a good thing actually to take even to a bedside or even have in your office. So there are cards that are for creating rapport and getting to know each other. So they have statements in them, like, you know, giving a situation, how would you handle that? Oh, what do you like? Your best food, you know, a city I would like to go to one day in my life, my best subject, whatever. So you're playing that, and I use it a lot with adolescents because, you know, adolescents are not voluntary clients. They will come when they are not happy because the school said, or they were suspended, or they don't want to talk to anyone, they just want to stay in their room and be on their phone. So they come with a lot of suspicion that what we are going to talk about, you're just going to tell my parents. So I bring out the cards and we play the game card for about 10 minutes as I'm gauging and doing my MSc there. So I'm looking at these adolescents in terms of the way their cognition, their speech, all those things that are in the MSc. So story cards you can also make your own. Like these are story cards that I had created sometimes when those times when we don't agree with each other as Kenyans and we decide to fight, and then people are displaced, and there are children who go through all those crises. Yeah, next. Same, that's just a part of these story cards. Okay, I will just go back. So I was thinking about the symptoms of PTSD, the intrusive thoughts. Is it hypervigilance? All those kinds of the I think the 4 clusters are they 4. So I was working with young children and I didn't know how to unpack those. So I got an artist and I was trying to describe those symptoms, and I said, go and draw for me that. Like if somebody is experiencing this and that, and it's a child and they can't tell you that's what they're experiencing. So they drew for me these things. It was for a specific, this was post-election violence. So they drew me this, and I would go to children who had been displaced, and I would put the cards on the table or just hang them on the wall somewhere. And I would say, point to me how you have been feeling since this incident happened. And then, I would ask about the somatic symptoms. Where do you feel it in your body? Is it a lot? I'll do scaling, so that they can tell me is it a lot or not. So through this, you are able to even get that diagnosis. Next slide. Next one, it's the same. Okay, so of course there has to be a dollhouse. So if you have your office there, the dollhouse in the hospital, I don't know, but home is where things happen. There are good memories, there are difficult times, and there are treasurable times in homes. And as a play therapist, it's important to have a home. And this home is children who create in there. So you can say to the child, make for me your family doing something. Or in this house, in one room, make for me from the shelf something, the things that make you happy. And then in another room, make for me the things that make you sad. And then make for me the things you wish were happening in your house. So the child makes, and then they tell me what it is in every room, and we talk about that. Again, of course, it's something that we use in family play therapy with parents, where you can have the parent and the child create a home together. Next slide. I think it's almost like I'm done. We can go to the next one. Yeah. So of course there are challenges of working in medical settings. It's a controlled environment, but with creativity and just working with the other teams, I think it's possible that we can bring play therapy. And play therapy, of course, it is used in medical settings. And I hope that as we go to the last slide, I hope that through this presentation, maybe as doctors and as medical personnel, we can be able to think about the place of play therapy in our clinics and in the hospitals, because it's the medium through which we can be able to reach those children and be able to work with them in their journey of healing. Thank you very much.
Wow. Wow. Thank you so much, Florence. I'm sure we've learned a lot, not just on play therapy, but just how we can incorporate child-friendly techniques and, of course, be creative as we are trying to assess our children. I think I've heard you saying you're reading a story with a child, or there's a puppet, or you're playing with a child. And as you're doing that, you're doing the mental state examination instead of asking the child those questions you usually ask. I think I was talking to some of the postgraduate students at Kenyatta and saying like it doesn't make any sense you asking the child like you ask them about the abstract thinking in such a structured way as though you're talking to an adult. So thank you so much for that presentation. I hope we've all learned. So if we have any questions, any comments, we're opening up a few minutes just to go through that. I think somebody's asking, where is the training for play therapy done in Kenya? Florence or the rest, you can answer that.
Yeah, and my colleagues, maybe they can be able to answer that one. If they are tuned in. And as they get ready, yeah, so if I don't say anything, you can add Olpa or Maureen. But okay, so like I said, at so at APTK, we have started rolling out, like play therapy trainings as part of professional development courses, like the way you do this, you're calling CPD, something like that. So we are bringing in people from other countries who have done play therapy. So for trainings, online trainings. But in Kenya, what I know is that there is no like specific play therapy training in and of itself. But of course, when you go to the campus, you will, it's a unit at master's level maybe, or at doctorate level, or sometimes even in undergrad. I know Daystar has a master's in child development, which has play therapy as a full unit. Amani Counseling Center has a certificate of 100 and I think 50 hours, 1 day a week, which they train in play therapy. So for me, that's what I know is available in the country. But out there's a bit of online trainings of play therapy. Olpa, would you like to say something in addition? Or Maureen?
Thank you, Florence, and thank you for that elaborate presentation. I think you've said, you've just covered all the areas that give trainings on play therapy.
Okay. Yeah, so when we have those trainings, maybe we can be sending the flyer, and then those who are interested can join.
Okay, thank you. Dr. Ongetra is saying thank you very much for the detailed and creative work you've done to assess the children. Your passion for children's mental health and work with them is very commendable. Also, Janet is saying thank you for sharing your wealth of experience. It has been very insightful. So Dismas is asking, what has been the experience assessing a child while putting on a clinical coat, given the fact that children fear injections?
Yeah, they do. They do. Okay, you see, personally, I don't put on a clinical coat, but what I know about me is that when we are doing intake with children, sorry, my dog is barking. I hope it's not. I can go to another room. Okay, sorry.
It's all right, just go ahead.
Yeah, I'll close.
That's Florence's baby.
Yeah, that's what I mean. So during intake, so personally, I see the parent before I see the child so that I can do a full intake with the parent. And then we talk about preparing the child to come for therapy for that initial assessment session. So we talk with the parent about explaining what therapy looks like and to not use the word doctor, actually. Now, you guys, I don't know whether you would be comfortable with not using the word doctor, but I tell them, you can tell the child about there's this person whose job is to talk with children about their feelings. And when you go there, you will find this and this. So I think that a child, the court might not be a barrier if the nonverbals and the ability to create rapport with the child is enhanced. If the court has to be there, yeah, it would be good if the court is not there. If in court police officers are not wearing their uniform in children court, they don't. Actually, even the judges are removing their black for children cases. So I don't know about maybe KPA as an association, you might want to think about that when you have child clients. And because this is an intentional effort to make it child friendly and to help the child to be able to open up. So depending on the way the interaction is, sometimes even that table, I might not wear a coat, but then there's this big table between me and the child, and so that becomes a barrier. But just having that space on the other side where I come out of it and we are just seated with the child, maybe might be able to provide that environment in which now assessment is possible.
All right, thank you. We'll think about that. I know some people are starting to wear scrubs and colorful things, so maybe that'll make the child feel more comfortable. But then again, as you've said, you have to establish that rapport. So thank you for that. I don't think there's any other questions. However, I'm seeing Dr. Mary Njuguna saying there's a Kenyan movie on Netflix called Supermodel that is showing how play therapy might help a sick child. So if you get time, maybe you can watch it. Okay, so Florence, it's 8:30. We were 35. We're supposed to clear the webinar at 8:30. Maybe you can just give us like a summary or a parting shot of what you'd like us to take out of this, and maybe future collaborations we might have together.
Yeah, especially that part of the future collaborations, because one of the things that our association, like counselors need is also to understand a bit of the, the psychological disorders and how they might show up in a child and when to refer, because you might find, maybe there's this counselor or psychologist who is hanging on to counseling a child, and it is really clear that medication will work better, or both medication and counseling will work better. So the need to just harness our resources, and then of course for us as play therapists, there is what we provide. So that kind of referral and of course the collaboration, we would, as APTK, collaboration with KPA is very important, because we can be able to exchange those trainings. We can come to your trainings, you can come to our trainings, maybe we can hold things together. Maybe you have a mental health day, children are coming, we come in there and be able to just be able to work together, even as you dispense the medications and stuff like that. We also do a bit of that community CSR. Yeah.
All right, thank you. I hope that dog is not in distress. But thank you so much, Oprah, and thank you, Oprah, thank you, Maureen and Florence for joining us. And also just thank you everybody who has taken the time to just join. I hope you've learned something. I hope this has gotten you excited about how you're going to go back and assess your children and be like bit more friendly, use more friendly techniques and be more creative, because some of these things are small things you can do, like the cards and all that, and it'll actually go a long way. And also it's good that we have known about this APTK, we've known about Florence. So if we have any clients of ours who would benefit from this, can always refer, and also they can refer back to us if any of the child needs more assessment from our side. So asante sana. I think we can end the webinar. Good night, everyone.
Thank you.
Thank you so much. Bye bye. Good evening.